So we looked at symptoms of cystitis and pyelonephritis. We analyzed the results of urinalysis. We ensured urine cultures are taken in patients with pyelonephritis and recurrent cystitis. We also recommended effective drug therapy for treatment of cystitis and pyelonephritis. Now, the next learning objective is change empiric therapy to pathogen-directed therapy based on urine cultures and susceptibility results. The concept of collateral damage refers to unintended ecological adverse effects of antibiotic therapies, and this includes selection of drug-resistant organisms as well as unwanted development of colonization or even infection with multi-drug resistant organisms. Here's how selective pressure works. The normal flora includes a diverse population of bacteria, and this diversity is beneficial for health because these organisms can actually compete with pathogenic bacteria for growth. So they actually prohibit the growth of pathogens. Although these bacteria are beneficial for health, some of them could actually include genes for resistance. So imagine these two strains of bacteria that are pink, they actually include genes for resistance. Although they are resistant to antibiotics, they are not really causing any infection or any problems in the host. Now imagine that you start using antibiotics for an infection. While the antibiotic is important for killing the infection, the antibiotic can also kill all these beneficial flora. And when it happens, all the flora that are susceptible to the antibiotic will die, except those beneficial bacteria that were resistant. And because those resistant bacteria, although they are not causing any problem, because they stay around, they actually become the dominant species as part of the flora. And now, the majority of the flora include genes for resistance. And then when the day comes when an actual pathogen invades the host and causes infection, these flora can actually transfer those resistant genes to the pathogenic bacteria from plasmids and cause infections that are resistant to antibiotic. And this is referred to as selective pressure, where the resistant organism becomes the dominant species. This selective pressure is greatest with broadest antibiotics, and the risk is lowest with narrowest antibiotics. So therefore, it is important to keep that in mind, and when we select antimicrobial agents for our patients, to choose the narrowest possible option. This pyramid is designed to help you understand broad versus narrow spectrum of activity. It is important to know that there is no such thing as a tiering system when it comes to broad versus narrow spectrum of activity. I have created this pyramid just to help you understand broad versus narrow. Now, the higher you are on the pyramid, the narrower the spectrum of activity, and the lower you are, the more broad the spectrum of activity. And broad versus narrow is not really a head count of how many organisms are covered by a specific antibiotic, but rather it is the propensity of causing collateral damage. So tier 1, which is considered pretty narrow, is essentially the urinary antibiotics, so nitrofurantoin and oral phosphomycin, as well as penicillin. So penicillin is considered the narrowest antibiotic when it comes to beta-lactams, and nitrofurantoin doesn't really go anywhere in the body other than the urine, so these agents are unlikely to cause collateral damage in the body. Slightly higher, so these are, tier 2 is still pretty narrow, but relative to tier 1, slightly broader, and these are first generation cephalosporins such as cefazolin, and also ampicillin and trimsulfa. So tier 2 is also pretty narrow, and these are good agents to de-escalate when we are using broad spectrum antibiotics. Now, I'm not going to be able to fit everything in there. So for example, I'm skipping second generation cephalosporin, so you can think of second generation between tier 2 and tier 3. And tier 3 includes third generation cephalosporin such as ceftriaxone, as well as ampicillin sulbactam and amoxicillin clavulinate. Now, these agents up to tier 3 do not have activity against ESBL producing agents. But, when you get to the third tier, it's actually pretty broad spectrum. Now, tier 4, slightly more broad than tier 3. What's unique here is that ertapenem and gentamicin, they do have activity against ESBL producing agents. ertapenem is a carbapenem that does not have activity against Pseudomonas, and gentamicin is an aminoglycoside that recently it is decided that it no longer has activity against Pseudomonas. So for that reason, because they don't have activity against Pseudomonas, they are placed in tier 4. Now from tier 5, this is where we get Pseudomonal activity. So everything in tier 5 has activity against Pseudomonas. And this is considered pretty broad. So unless you are trying to cover for Pseudomonas, you shouldn't really be using these agents if you have options. So cefepime, which is a 4th generation cephalosporin, ceftazidime, which is a 3rd generation cephalosporin, piperacillin tazobactam, fluoroquinolones such as ciprofloxacin, levofloxacin, and also the aminoglycoside tobramycin is pretty active against Pseudomonas, and amikacin is considered active against Pseudomonas in the urine only. Aztreonam is also a beta-lactam that's active against Pseudomonas. And tier 6 is actually more broad than tier 5. So these are pretty much carbapenems as well as ceftolozane tazobactam. These are not only active against Pseudomonas, but also active against multi-drug resistant Pseudomonas. So if you have Pseudomonas that's resistant against tier 5, tier 6 will still remain an option. So for that reason, they're considered more broad. And in the same sense, tier 7 is more broad than tier 6, because if you have pathogens that are resistant to tier 5 and 6, tier 7 may still be active. So you really want to reserve these. And in most hospitals, tier 7 and as well as sometimes some agents from tier 6, such as ceftolozane tazobactam, they're typically restricted. So you would need approval from the ID team to be able to use these agents, not only because you want to reserve them for resistant pathogen, but also these are pretty expensive. It's important to consider drug concentration in the urine and renal tissue when thinking about treatment of cystitis and pyelonephritis. So in this table, I'm showing you on average how much of each drug goes to the urine, and it's not that a specific number is a magic number, and certainly you don't need to memorize this number, but I just want to showcase that a couple of them have very poor concentrations in the urine. So clindamycin has about 10% in the urine, and moxifloxacin about 20%. So these two are actually considered pretty poor urinary concentrations. And one thing I want to note about nitrofurantoin, note that about 50% of nitrofurantoin goes to the urine, which might make you think that the other half stays in the blood, but because it's readily metabolized by all tissue, you're not going to have a significant concentration of nitrofurantoin in the blood. So anytime someone has bacteremia, nitrofurantoin is not really going to do much in the blood. Now it's important to consider that nitrofurantoin and oral phosphomycin should not be used for treatment of pyelonephritis because they do not penetrate renal tissue. So it doesn't matter how much of it gets to the urine, but because the kidney tissue is where the infection in pyelonephritis is, you should avoid them in pyelonephritis, but they're fine for cystitis alone. Moxifloxacin and clindamycin, as I showed you, have very poor concentrations in the urine, so they should not be used for cystitis or pyelonephritis. And lastly, should avoid tetracyclines and tetracycline derivatives until more studies become available. So something like doxycycline may have sufficient concentration in the urine and some of these other tetracycline derivatives, but clinical studies are lacking, and two recent agents that came to the market, omadacycline and eravacycline, they were both tested in randomized clinical trials of patients with urinary tract infections, and both of them failed to achieve non-inferiority to the standard of care. So because two agents have already failed treatment, it's important to avoid this when possible until more studies become available. Now, here are the recommendations from the 2024 IDSA guidance on the treatment of antimicrobial resistant gram-negative infections. For uncomplicated cystitis specifically due to ESBL producing Enterobacterialis, the preferred regimens are nitrofurantoin or trimsulfa. Alternative regimens include a single dose of aminoglycosides, oral phosphomycin only if it's E. coli, and fluoroquinolones such as ciprofloxacin or levofloxacin and carbapenems. And they specifically say to avoid doxycycline, amoxicillin clavulanate, cefepime, and cefamycins. For pyelonephritis or other complicated UTIs, again, due to ESBL producing Enterobacterialis, the preferred regimens include trimsulfa, fluoroquinolones such as ciprofloxacin or levofloxacin, ertapenem or meropenem or imipenem, and alternatively once daily aminoglycosides. And this is not just a single dose, this is a full course of treatment. And again, they say to avoid nitrofurantoin because this is pyelonephritis. Oral phosphomycin should be avoided, as well as doxycycline, cefepime, and cefamycins. Let's take a look at duration of therapy for uncomplicated UTIs, which is essentially cystitis. And for this, we will go to 2010 IDSA guidelines for uncomplicated cystitis. And because that guideline is specifically in women, that's why we have, in women. So again, you can probably use similar recommendations in men, but you have to keep in mind whether, the patient is likely to have prostatitis or not, because if they do, longer duration of therapy may be needed. And also you need to consider whether the agent you use has penetration into the prostate. But let's focus on women. So nitrofurantoin, 5 days of treatment. Phosphomycin is a single dose for oral phosphomycin, and pivmecillinam is for 3 days. For duration of therapy of complicated UTIs, which includes pyelonephritis, let's take a look at women. So this is from 2025 IDSA guidelines. So if you use fluoroquinolones, 5 to 7 days is sufficient. And they say for non-fluoroquinolones, 7 days of treatment. And of course, non-fluoroquinolones will be IV beta-lactams and trimsulfa. Now, PO beta-lactams, there is limited evidence for using them for 7 days. So although the guidelines don't say specifically 14 days, many experts recommend to use 14 days of PO beta-lactams when it comes to treatment of complicated UTIs such as pyelonephritis. Now keep in mind that these total durations of treatment includes the empiric therapy. So even though the empiric therapy may have been a different agent, so if somebody, let's say, received 5 days of 5 days of, let's say, IV beta-lactam, and then they switch to PO beta-lactam, you will essentially subtract 5 from 14, and the difference would be, essentially oral beta-lactam to finish the course. Or if somebody had already received 5 days of fluoroquinolones and switching to PO beta-lactam, you may not need this 14 days. You might say that actually we are done with treatment. So, you may question why we're switching to PO beta-lactam. Now, for men, there's a couple of things to consider. If the patient has fever or bacteremia, it's likely that 7 days may not be enough. So 10 to 14 days is recommended. The same if the patient is suspected to have prostatitis. And, we do not cover prostatitis in this course, but again, for that, you will need longer duration of therapy than 7 days. Outside of these two things, patients will be treated similar to women. So if it's fluoroquinolones, 5 to 7 days, and non-fluoroquinolones, 7 days.
So let's take a look at the case study. So let's say CR is a 50-year-old woman with no significant past medical history and no known drug allergies, who is being treated empirically for pyelonephritis with ceftriaxone 1 gram IV every 24 hours. So let's say today is day 4 of treatment, and she's clinically well. Here's the results of the urine culture. So the organism is E. coli, and the susceptibility results have come back. So basically, R means resistant. So amoxicillin clavulanic acid is resistant, Ampicillin sulbactam is resistant. Cefpodoxime is susceptible. Ceftriaxone is susceptible. Ciprofloxacin is resistant, and trimsulfa is susceptible. So what would you use? So far it's been ceftriaxone. Ceftriaxone is IV, and at some point, if the patient is ready to go home, we can change this to PO. So ceftriaxone only is available as IV. So but first of all, you want something that's susceptible. You don't want to use something that's resistant. So augmentin, for example, is PO, but because it's resistant, we're not going to be able to use it. So from the things that are susceptible, trimsulfa is available PO, and so is cefpodoxime. Cefpodoxime is a third generation cephalosporin that's available as PO, so you have two options left. So between the two, the correct answer would be Bactrim, because PO beta lactams don't get enough concentration in the urine. So if you do have options, PO beta lactams should be your last option. So for example, if this patient happened to have sulfa allergy, then trimsulfa would not be an option, and then you can use cefpodoxime. But since this patient does not have sulfa allergy, we would go ahead and choose Bactrim, or trimsulfa would be the best option.